Sorry, I thank you so much for the kind introduction and the invitation to be here today. I reformatted all my slides to this national meeting standard, which of course means that it doesn't always fit using the normal format. So I apologize for that. It is a great pleasure to be here. I really look forward to giving you an overview of PD-1 inhibitors in melanoma and also touch upon some of the ways we're trying to predict who might be most benefited by these therapies. It's a little bit daunting going after Dr. Weber because he truly is one of the leaders in the field of developing these drugs, but I'll give it a shot. So this is a fundamental truth. Every cancer that's ever been diagnosed has figured out how to defend itself. Obviously, it's not an entity. It's an entity. It's not a person, but it's able to defend itself against the immune system. It's just true. If you have cancer that's been diagnosed, if you have an X-ray or a CAT scan that shows cancer, that somehow figured out how to get around your immune system. And so the guiding principle of immunotherapy is really that an individual's cancer can be eradicated if we can just somehow instruct the immune system to eradicate it. So that's a guiding principle. And so this is a not so recent proof of that principle. So this guy who looked pretty young at the time but is long past dead now, if you can see, that's New York Times, 1906. This guy's named Cooley, and he developed a toxin. And the reason he developed a toxin is he was an observational physician, and he saw a patient who got very sick, had tumor in his neck. The patient got septic, which means he had bacteria in his body. The bacteria that he identified was probably Streptococcus. And the patient almost died of infection, but didn't. And when he recovered from his infection, he also recovered from his cancer, that his body had got rid of his cancer. And he put two and two together and said, there must be something here. And so he began to inject people with streptococcal toxin, which is an interesting concept. And it didn't really catch a lot of fire. It probably made people feel like they were on fire, but it didn't catch fire in general. However, the principle was there. And ultimately, some of the principle, or some of the concepts that he began to develop was weaponized into a drug called high-dose interleukin-2. And there may be some people in the audience today that have received high-dose interleukin-2, and Cooley's toxin is basically a poor man's IL-2. It's everything started. So why did this work? Well, you inject the toxin, it triggers all kinds of stuff from happening. Cytokines are these soluble factors that an old doctor from Greece called Galen called evil humors. And these evil humors rev things up, and then the immune system comes in and destroys the cancer, and then you don't have a cancer left. That's the concept. High-dose IL-2 just takes sort of that injection out and gives the cytokines as opposed to giving this toxin. So let's go to a more recent proof of principle. So this is the original publication of actually it's the second publication, but the more popular to be shown at meetings publication of the drug nivolumab, or Opdivo. And actually, I am aware that this is a melanoma conference, but this is the reason that everybody in the medical community cares about immunotherapy. We care about immunotherapy. We've cared about immunotherapy. Obviously, our patients care about immunotherapy. But business is not that excited about treating a small disease, right? They'll do it because they get their drug to market. But they really, really, really are excited when they begin to see responses in lung cancer. And that's what happened. So this actually changed everything. 5 years ago, there was one company, maybe 7 years ago, there was one company with immunotherapy. It was Bristol Myers who had purchased their immunotherapy portfolio from a different company. And they defined their group that did immunotherapy called immuno-oncology. There was one IO company, or one company that had an IO division. Now every company that's large enough has an IO division, and it's because of this. And that's good for everybody in this room. It's good for patients because you have drugs that are being developed, not just the drugs that have gotten to market, but other drugs, new combinations are happening because there's money to be made for people who are making these drugs. It's good for providers because we actually have stuff to offer, and if things stop working, we may have additional things to offer on clinical trials, looking at new ways of modifying the immune system. So this is what changed everything. For us, we've been treating patients with high-dose IL-2. We were treating patients with ipilimumab. We knew that this could happen. But the lung cancer doctors didn't believe it, and the colon cancer doctors didn't believe it, and goodness knows that the neuro-oncologists didn't believe it, but we did, and this made believers of them. So why does this work? Well, it's complicated. There's a lot of things happening here. And so in some ways, take a step back, we'll talk a little bit about how does the body kill cancer. Well, this is, I suppose the best way of describing it is a synapse or an interaction, and that's not working, but maybe this. Okay, yeah. So I have this cursor here. So this thing in the middle is the T cell. This is the working, sort of the grunt of the immune system that destroys infected cells, and it destroys cancer cells. And it has to be activated. Where's my little guy here? There's my cursor. This thing is one of the things that helps to activate it. And the way it activates it is it begins to say this thing here, anything that has this on it, go get. And these things help to signal, say, or maybe they say these things don't go get, stop. These things go get. And the way they do that is this interaction of all these things over here. And then once it gets activated, it goes into tissue, and it interacts with tumor, or it interacts with other things. And these help to say stop. And so I'll kind of move forward. So first thing you need is tumor recognition. The tumor needs to be identified by the immune system. And that happens in that blackened thing. And then the immune cell needs to activate. And this is probably a simplified version of what happens. It's really, really complicated. And then the tumors need to be infiltrated by the immune system. Essentially, the army needs to get to the enemy. Okay, so how does this work? Well, it is all about the T cell mostly. There's probably many other things that contribute, but for the purposes of this conversation, it's all about the T cell. And what we're looking to do is get a T cell that recognizes, gets into the tumor, and does its thing and destroys a tumor cell. And for this slide, I have to recognize Dr. Jen Wargo, who I stole this from. Now, that's true. She gave it to me. She probably didn't know she gave it to me, but she did. Okay, so how can we improve activation? Well, one thing we can do is we can target the brake. So if you have a braking system that prevents things from going, obviously in a car, that's the thing that all of us recognize most. And the way we target the brake with immunotherapy is this drug called Yervoy or ipilimumab. This is the first drug that was developed as a so-called inhibitor of these checkpoints, which are these things over here that are in the black box, the things that are regulating and activating the cell. So if you target the brake, you release the brake, maybe, just maybe, the car will go. Now, it's not every car. If you're on a flat surface or on an incline, maybe an incline you go backwards, but if you're on a flat surface and you release the brake, you don't go anywhere. So things still need to be ready. But if you're on an incline and you release the brake and you don't have, you're neutral, you're going, right? And so essentially, this drug doesn't work for everybody, but it works for some people who are ready. Their tumors are ready, their immune system's ready to go. All they need is a little bit of release of the brake, and they can go. So that's one way we do this. Another way we can do this is immune infiltration. So if we can get the immune system into the tumor, we might have a chance at destroying that tumor. And so there are a lot of different ways that people can describe and a lot of analogies for PD-1 and PDL1 inhibition. I like barbed wire or a shield or a moat, whatever it is. You do have an army trying to get in to that tumor, and the tumor doesn't want that army in there. And so it's protecting itself, and it's protecting itself with this protein called PD-L1. And that, when a T cell gets activated, PD-1 comes on its surface, and it goes in, and then it starts interacting with the tumor, and the tumor says, I don't like you here, stop. And it interacts using PD-L1. So PD-1, T cell, PD-L1, tumor, there's an interaction, and it prevents the tumor from destroying it. Why does that thing exist? Well, it exists because most of us in this room have had a bad cold or a flu, and we get sick, and the flu gets into our lungs, and we didn't know it, but our immune system got activated and went into our lungs. Actually, we did know it because we were coughing. Maybe couldn't breathe particularly well. And then somehow we started breathing again, and we didn't die. And the reason our lungs survived was because it used something like this to prevent the immune system from destroying it. So cancer cells are clever. I like that word that Dr. Weber used. They're clever. They're not smart. They're clever. They figure out how to use the things that normal cells use, but they use them really well. And all they care about is surviving. They don't care about if the host survives. They care about if the cell survives. So how does this look when we give it to patients? Well, these drugs are really promising. Now, obviously, many of them are approved. So this was the first trial of pembrolizumab, which at the time was called lambrolizumab. I'm not going to blame Dr. Hamid for incorrectly naming it in his paper. At the time, it was actually called lambrolizumab. They changed the name. These things apparently happen. But as Dr. Weber said, we have waterfall plots. Lots of downward deflection of the waterfall plot. That's good. That next thing is a spider plot. Down is good. Staying down is even better. That means your tumor not only shrunk, but it stayed shrunk, which is bad English. Atezolizumab, PD-L1 inhibitor. Tumors get smaller. And again, maybe not quite as, and then MDX-1107 was a PD-L1 inhibitor that's no longer being developed. But again, there were responses. What also became apparent that anti-PD-1 therapy is better than chemotherapy after ipilimumab. So on the left are progression-free survival curves of pembrolizumab versus chemo in patients who'd already received ipilimumab. It became first. So we were then comparing how these two drugs worked, chemo or pembro, in patients after they'd received ipi. Turns out it works better. That's good. And then the next one is from a trial that Dr. Weber led, which was nivolumab versus chemotherapy. There's the waterfall plots. It works better. It doesn't just work better for waterfall plots. It works better for progression-free survival. It works better for overall survival. You do better if after you receive ipilimumab, you get nivolumab versus if you got chemotherapy or pembrolizumab after chemotherapy. It turns out also frontline anti-PD-1 therapy is better than chemo. So this is a trial that was actually unethical in the United States. And it was unethical in the United States because we had ipilimumab approved. So if you were a patient with metastatic melanoma, you would not have wanted to be randomized to a trial where you had a 50% chance of getting chemotherapy. However, in Europe and other parts of the world, ipilimumab was approved only after you'd received another drug. So this was technically a trial that had some ethics that was okay outside the US, but it was not an ethical trial in the United States. And in many ways, this is kind of like me playing one-on-one against Kobe Bryant. Kobe Bryant's on the left, I'm on the right. All right, I figured this out because I'm a little bit older than Kobe Bryant. There was never a time in my life that I could have beaten him in basketball. Ever. Like LeBron, I could have beaten him when he was 5 years old. There's never a time I could have beaten Kobe Bryant. All right, and so if I did play Kobe Bryant, there'd be a lot of this. Right? He'd be fist pumping all over the place. Or maybe he'd feel bad for me and he would just like pick me up off the ground. I don't know. All right, I'm a Celtics fan though, so probably not. Okay, so what else do we know? Well, frontline anti-PD-1 therapy is better than IPI. And here is sort of more expanded. So this is now, we've looked at PD-1's better than chemo after IPI. PD-1's better than IPI. Now anti-PD-1 therapy, I'm sorry. Yeah, and now it's, sorry. PD-1 therapy better than chemo after IPI. PD-1 therapy better than chemo before IPI. PD-1 therapy better than IPI. Okay, and these are survival curves, and essentially what is established is that patients live much better and they progress less quickly if they receive PD-1 therapy first versus getting IPI first. And this is a fairer fight, but it still wasn't much of a fight. Okay, so what's next? Well, actually it's what's now. So it turns out if you combine these two drugs together, you get amazingly deep responses. That's the waterfall plot that almost looks like it's not a waterfall at all. And that spider plot that looks like not much of a spider plot. It just looks like everybody does really well. Almost everybody does really well. And when you compare this, these are progression-free survival. You're much less likely to progress if you got the combination versus if you got the single agents of either drug. Blue is nivolumab. Green is ipilimumab. Red is the combo. And waterfall plots look better. So more responses, more robust responses. So all this is looking good. But here's the rub. This combination is toxic. And it's toxic in a way that at least 50 to 60% of patients get immune-related side effects. Now, that's all well and good. We often do trials and we do combinations and we see that there's a 50% severe side effect rate. No problem. We can deal with it. You stop the drugs, they get better. You stop dabrafenib or trametinib, your fever goes away. You give steroids, your fever goes away. Here, these 50 to 55% of patients that have these toxicities are often in the hospital getting intravenous steroids and are not feeling very well. And then they're going to be on steroids for 4 to 6 weeks. We can get people through it, but we have to know that it's the right thing to do for that person. Because if you give nivolumab by itself, 16% of patients have that degree of severe toxicity. Interestingly, ipilimumab is 27%, so ipi's more toxic than the better drug nivolumab. So this is the major issue right now, where we are right now. And then the question is, well, can we sequence? Can we give nivolumab then ipilimumab, or give ipilimumab then nivolumab? And maybe if we do that, we can have good outcomes. And this is data that Dr. Hody from Dana-Farber presented, and Dr. Weber will be giving the update. But when you do this, you begin to see that the upper curves are the sequencing. So blue is you start with NIVO and go to IPI, and green is you start with IPI and go to NIVO. And that's the first time you scan, and then you automatically switch. And then after the automatic switch, you see, and essentially the curve on the blue curve on the right looks about as good as the orange curve on the lower left. So the outcomes at 6 months look about as good as if you combine. It turns out that it is toxic to do that switch. When you go from NIVO to IPI, there's more toxicity than you go from IPI to NIVO. And whether or not patients do dramatically better, well, we'll have to learn more about that in a few weeks from Dr. Weber. So what about survival? What we really care about, we love responses. It makes everybody feel good, right? But we want our patients to be alive. So what about survival? Do we know that combining these two drugs and exposing patients to higher toxicity leads to better outcomes? We don't. All we know is that this is a table that was buried in the supplemental figures of this trial. And it showed that at median follow-up of 1 year, so every patient, half of patients had made it through a year of follow-up, the number of deaths were exactly the same if you'd gotten the combination of IPI and NIVO or if you'd gotten NIVO to start. There were more deaths if you got IPI first. So we don't know yet whether the squeeze is worth the juice, or I don't know what the analogy is, but something like that, whether or not it's a good idea to give the combination for everybody. It's okay to give the combination for some patients. There's definitely an appropriate time to do that. But we don't know whether we should give offering this to everybody. This data would suggest we shouldn't in the setting of that toxicity. So what about survival of the sequencing study? Well, Dr. Weber will have to tell us about this sometime between June 3rd and June 7th. I think it's June 4th. Is it public now? Oh. NIVO to IPI is better. You're actually more likely to be alive if you... And it is shockingly so. It is dramatic and is a fabulous piece of data, and I'm not sure why you're not giving the talk yourself and why it's a poster discussion, because it's really important data. All right, the summary of clinical development of anti-PD-1, PD-L1 therapy. So in terms of effectiveness and safety, anti-PD-1 antibodies are better than IPI and better than chemo. And they're better tolerated than IPI and chemo. And so if many of you remember these commercials from the 80s, right, where all these football players and other sports legends were arguing, tastes great, less filling. Well, it turns out that it tastes great and less filling. And I can't say I came up with this. One of my patients did when I was describing IPI versus NIVO. And the guy, tastes great, less filling. It's like, yes, I'm going to use that someday. Well, today is here. All right. Well, how about sequencing? Well, NIVO, then IPI is better. And I said it was better from waterfall plots. It's better in survival. It's better. IPI-NIVO is better than IPI, sort of. And I didn't show that survival curve. But it turns out that if you do, there was a trial which randomized patients the combination or IPI, and then when patients progressed on IPI, they got NIVO. The survival curves are surprisingly similar. They actually weren't significantly different. And so that's interesting. And then is IPI-NIVO better than NIVO? We don't know. but that limited data of the 1-year survival would suggest that maybe not. And maybe it's all in the back end. Maybe there's going to be more cures if you give the combination up front, but I'm not sure. More to follow. This is the point where apparently I put in a lot of different things. Okay, combinations. So Ipi-NIVO is associated with unprecedented responses and toxicity. Question of whether or not there's improved survival compared to single-agent anti-PD-1 antibodies. There's a lot of other things happening. All right, there's more immuno combos that are happening, that are beginning to be presented. It's a really exciting time to be doing this. And as Dr. Weber alluded to, the combination of immunotherapy and targeted therapy is happening. There's some really, really cool data that's being generated. Some of it will be presented in Chicago. Some of it will be presented in Europe in September. And I guess the one thing, I don't know how, this was a very complicated slide, and apparently I put in a lot of different things that I had to hit the button a lot. We'd love to know who we should be offering what to. And the way to do that is through these things called biomarkers. Well, what's a biomarker? Well, a biomarker is essentially some test you can do to a population to say, you have this, and I think you're going to do well. Maybe it's you're just going to do well. Or you have this, and I think you're going to respond to this therapy and not to this therapy. Something like that. And so the best biomarker that we've had over the last 10 years has just been mutation. If you have a BRAF mutation, you might respond to BRAF inhibitors. If you don't have a BRAF mutation, you won't. If you just look at how those patients do, the BRAF mutant patients don't do any better, maybe do slightly worse than non-BRAF mutant patients before BRAF inhibitors. But with BRAF inhibitors, they clearly do better. So that's a perfect biomarker. What we'd love to have is a blood or tissue assay to say, you are going to respond. Or you're not going to respond to our traditional therapies, and why don't you go get something else? You need a clinical trial. You don't need a clinical trial. Although we obviously make our living doing clinical trials, so we're biased. We think that everybody needs a clinical trial, but that's not necessarily true. There are lots of people who don't live near hospitals that have clinical trials that can be perfectly well suited with standard therapy, particularly if you can predict that they're going to do really well. So there's this emerging model of predictiveness, of responsiveness to PD-1 therapy. So it begins with this concept of mutational load. So this is becoming a very famous picture. It's really simple, right? Not really simple. It's relatively complicated. But the way it is all these little ticks are the number of mutations that a tumor has. And that's going up and down. And each column is a different tumor type. And not surprisingly, the one that I highlighted is melanoma, because I did remember that this is a melanoma conference. What's interesting is melanoma is the cancer where immunotherapy has always been somewhat effective. And there's a lot of mutations. And if you start reading the names, which of course you can't because the screen's not big enough and the type's not big enough, all of the cancers that are hugging the right side of this screen are cancers where there's PD-1 inhibitors that are approved. Non-small cell lung cancer, squamous type. Non-small cell lung cancer, non-squamous type. Bladder cancer. Gastric cancer. I'm going to read it. Stomach cancer, that's gastric cancer. Esophageal, colorectal, head and neck, lymphoma. All right, those are all on the right side. And so there is probably something to that. So why does this matter? Well, if one of the things that has to happen is your immune system needs to recognize that there's something wrong, the more abnormal your tumor is, the better chance it has at figuring this out, right? So if your tumor looks like a Martian, your body should be like, we need to get rid of this Martian, okay? Whereas if your tumor looks an awful lot like you, well, we're basically born not to destroy ourselves with our immune system. That would be really bad. We wouldn't live very long, and our species wouldn't have gotten very far. So we have to have these built-in things. So the more abnormal your tumor looks, the more mutated your tumor looks, probably the more likely you are to respond. But why is that? Well, these little things that are in there, there's this concept that some mutations are totally random. They're not these driver mutations that Dr. Weber is talking about. There's these totally random mutations that lead to a little abnormal protein that your cells don't normally have on it that your immune system can recognize. You don't usually have a lot in any tumor that your immune system probably can recognize, but they do exist. And the more tumor mutations you have, probably the more neoantigens your tumor has. But it doesn't predict necessarily whether you're going to respond or not. That there's lots of other things that the immune system has to get around in terms of tumors. But this is data. I just like putting these things here so that Dr. Hamid can steal my slides and present them someplace else. All right. Another thing that has to happen is once you have those antigens, those neoantigens, they need to be presented on the cell. Because if they're just hiding in the cell, your immune system can't recognize it. So there still has to be a flag on the surface that says, come get me, if you can. And so we actually did some work looking at one of these flags called MHC, specifically MHC2, and it looks like if your tumor has it, you respond better, and if your tumor doesn't have it, you respond less well. And this is a collaboration with some folks at Vanderbilt University. They provided the test set, we provided the validation set. But really, it fits the model. You need to actually show off those antigens, those neoantigens, to the immune system. And then, finally, you need to have immune cells get into the tumor. And when they get in the tumor, you want them to destroy the tumor. So some work that was done not too far from here at UCLA showed that it turns out it's important where your tumor, that you need to have tumor cells that are infiltrated, that are invaded by your body's immune cells. And it even was better if they were if they had it surrounded. So if they had your tumor surrounded, you did better. If they were just kind of here and there, but not in an organized fashion, you didn't do as well. Those patients didn't respond. The patients who responded were the patients who had the tumor surrounded. That's kind of cool. And then the immune cells that are there, you can actually pick them up when you do these really sophisticated tests on the tumors that are expensive, and we spend a lot of money on grants doing that. So that's why we're always writing grants, because we want to test these things and figure this stuff out. If you have certain types of genes that are being expressed from your immune cells in the tumor, we can predict that you're either going to respond, like on the left, or you're not going to respond, like on the right. Again, the details don't matter, but it's the concept that matters. And so here's the predictive model. You have mutational load, which predicts neoantigen load, which you then need to be able to express those things on the surface, and then you need T cells. And if all that happens, that tumor is probably going to express PD-L1, right? It's a defense mechanism. The tumor expresses this when it's invaded. And so this is where PD-L1 expression happens, and then those are the patients that are probably most likely to benefit if you interact and interfere with that defense mechanism. And so what's clear is that PD-L1 expression is associated with better outcomes, with patients with melanoma, with patients with lung cancer, all of that. But the problem with that is if you look at those blue curves, which are the PD-L1 negative patients, this is with pembrolizumab, there's still a fair number of patients that respond or that are doing well 6 months later. So this is not yet a test that we should be doing saying, don't give them the drug or give them the drug. Because if you're negative, I'm not going to give you the drug, even though you have a 25% chance of having your tumor totally controlled in 6 months. No, I'm going to give you the drug. I don't care what it is. But maybe we can think about it in a different way. Maybe it can help us to choose who we should be offering the combination versus offering the single drug. And that data is here. If you express it, if you have high levels of expression, the orange and blue curves become superimposable. This is whether or not your disease is growing. It's, on the left is expression. On the right is non-expression. The curves are separate. Orange is the combination. Blue is the single agent of nivolumab. So maybe it's important there. Maybe if you're PD-L1 negative, you get the combination. If you're PD-L1 positive, you get the single agent. But the way that I've been thinking about it, and my colleagues may be able to comment in the break or not, whether they want to or not, but I use the combination when I need somebody to respond. That patient, I don't think, has 6 months to respond. They have 4 weeks, 6 weeks, 8 weeks. And so I want to maximize their chance of responding. So in the red box there's nivolumab by itself, the combination in the middle, and ipilimumab. And so the pointer's not working, but basically there's a 72% chance of response if you have the combination, if you're PD-L1 positive. And there's a 57% chance if you have nivolumab that you're going to respond. But if you're negative, it goes to 41 and 54%. there's still a better response rate with the combination with PD-1 positive than with PD-1 negative. So I still don't use this to discriminate who I should be treating with a combination, who I shouldn't. I actually look at the patient, look at the scans, look at the scenario, and make a decision, and I don't use this data yet. However, someday we may get there. So here's my summary. There's analysis of tumor, there's tumor burden, types of mutations, capability of being recognized by the immune system. There's analysis of the immune cells. Are they there? Where are they located? Do they have the tumor surrounded? Are they just sort of occasionally here and there? An army needs to be together, not separated. So if you just have cells here and there, probably not as effective. What types of immune cells? We didn't talk about the types of immune cells. I don't have time to do that, and it probably would bore you. But there are cells that kill tumor cells, and there's cells that block the killers. So that's important. Whether or not the cells are active, that gene expression stuff that costs lots of money. Response of tumors against the immune cells. Is there PD-L1 expressed? If there's not PD-L1 expressed and there's T cells, maybe it doesn't matter. Maybe it does. And then are there other immune checkpoint molecules expressed? And then maybe we'll begin to be analyzing blood and doing that. So to conclude, what I would say is, and Sir Winston Churchill, who's a wise man and a very crude man, but this wasn't so crude. He said, now this is not the end. It's not even the beginning of the end. Perhaps it's the end of the beginning. I think that's where we are, certainly with biomarkers, and probably where we are with immunotherapy. It is fabulous that 55, 60% of our patients with maximal immune checkpoint inhibitors respond to the therapy. That's great. That's not good enough. So we need to get better. Maybe we can just get better by figuring out who we should offer what to. That's good. But we still have a long way to go. And I think, despite the fact that he said this during World War II, that was a relatively short war. The war against cancer is a relatively long war. And I think that's sort of where we stand right now.